Good afternoon. Welcome to Medical Grand Rounds. We have a exciting Grand Rounds today, which I think has more speakers than anyone in the history of UCSF Grand Rounds. The topic is feedback in medicine. And the title of the talk is "You Don't Want to Traumatize Someone," quote unquote, exploring barriers to giving and receiving feedback in the Department of Medicine is, I think, the way we've titled it, but this really is of general interest to everyone. I think there's a general sense that giving and receiving feedback, the dynamics around it have changed over the last several years for a whole lot of reasons. One of the things I'm proudest of in the department, rather than just saying that's a fait accompli and doing a little bit of Days of the Giants about what feedback was like, when we were kids, we've taken this as a topic that we need to understand and study and get better at. And I think that will be useful for us locally and really for everyone else as this information gets disseminated. So the format today is a first lecture with 4 distinguished speakers and scholars in the topics related to medical education, and then a panel discussion with 5 more distinguished medical educators who will come up a little bit later. I'm going to just introduce the 4 speakers, and then Brian will introduce the panelists. And by the time we're done with all the introductions, there may not be much time for content, so I'm going to keep these super short. Brian Schwartz is the Associate Chair for Education, runs the educational enterprise in our entire department, which is enormous. He's also a professor of medicine and an extraordinary infectious disease physician here. Bridget O'Brien is a professor in our department and also an education scientist for the Center for Faculty Educators and the director of the VA Advanced Fellowship in Health Professions, Education, Evaluation, and Research. He's a renowned scholar in medical education. We have 2 fellows with us presenting today, which we're thrilled about. One is Griffin Plattner, who is a fellow in our National Clinical Scholars program, who has a real interest in medical education and health equity. And Jackie Vajta, who's a fellow in the Division of Hospital Medicine, also here at UCSF Health, who also has a strong interest in medical education. So with that, I will hand it off to Brian and look forward to the session.
Thank you, Bob. Really excited to be here today. As Bob had mentioned, this is the title of our talk is "You Don't Want to Traumatize Somebody, Exploring Barriers to Feedback from Department of Medicine Faculty to Trainees." And so over this hour, I'm going to start off our presentation by talking a little bit about a background around education in the Department of Medicine and feedback. And then Bridget, Jackie, and Griffin are going to talk about how we did work to better understand this problem. We're going to bring up our expert panel and get their input on the data. We will then propose some countermeasures and then bring the panel back up to hear their feedback. So I think most people here in the Department of Medicine know that we are huge and complex. We send our trainees to 3 sites: the VA, UCSF Health, San Francisco General Hospital. And these are all very large and complicated health systems on their own. We have an enormous number of trainees. We have over 400 GME learners. We have a residency that's over 180 residents. We have 20 ACGME fellowships, many non-ACGME fellowships. And then we also have many medical students that are rotating through our sites. And we have a lot of faculty teachers. We have over 800 faculty that are involved in teaching of all these trainees, the students, residents, and fellows. So large and complex. Now, how do we help a novice, let's say an intern or a resident or a fellow, really become what we want them to be a practicing clinician who's ready for independent practice? Well, we put them often in the clinical workplace, whether it's an inpatient setting, whether it's an outpatient setting, and they're working with faculty, and hopefully on a day-to-day basis, they are getting feedback that are helping them transition from a novice into somebody who's ready for independent feedback and really independent practice, and really feedback is at the core. So how does this feedback get from our faculty to our trainees? How does it get back to program leadership? Well, I think for those of you who have done patient care with learners in the clinical learning environment, usually your faculty is working with a trainee on a day-to-day basis and is giving oral feedback. about what they're doing, their plans, their communication strategies. And hopefully this is happening on a regular basis. At the end of that time together, usually the faculty are asked to give written feedback. And the system we use here is MedHub. And you can see these extra red arrows on top are the feedback and evaluations given by other faculty. This is compiled in MedHub as a set of assessment data. And then this assessment data is then transmitted to our clinical competency committee. The clinical competency committee, in partnership with the either residency or fellowship program director, will ultimately make decisions about trainee advancement. And so you can imagine in this scenario, if you're not getting data to the clinical competency committee, it can be really hard to make good decisions about the advancement of the trainees. And when I first took on this job about 2 years ago, I started getting signals that there were some concerning trends, that we were identifying that faculty had low completion rates for resident and fellow MedHub evaluations, and that the residents and fellows had been reporting low satisfaction with faculty feedback. And so when I identified that, I felt like we needed to collect more data and really understand the extent of the problem. And so I'm going to share a little bit of the data we collected. We looked at faculty MedHub completion rate and both looking at residents and fellows. And you can see that in 2017 and 2018, that we had around a 70–80% completion rate from our faculty. And over time, there's been a significant degradation in our completion rate. And you can see now in 22–23, now we're looking at more of 50–60% completion rate. And I think the importance of feedback was well known, and some of these concerning trends were identified. And Sandrine Van Schaik, who's going to be on our panel, was leading a program across the school, which included a feedback champion program. And what that did was it took some of our faculty in the department to every single division at all 3 sites and provided some faculty development to them and tried to help them be better at feedback. But you could see even after that intervention, there was a continued decrease in completion rate. We also looked at our ACGME survey data. So ACGME is the accreditation body for training programs. They do an annual survey of all the fellows and residents, and they ask them about 24 questions. And one of the questions that they ask them is, are you satisfied with faculty feedback? And this is the 2024 report, but I can tell you it's been an issue for many years, is that you can see that over half of our programs, including our residency, had satisfaction rates of our trainees well below the national average when it came to faculty feedback. So given that we knew that faculty development by itself wasn't going to be the solution, and this was a complicated problem, we decided that we wanted to really approach this in a rigorous way. And so the next steps were we were going to conduct a department-wide faculty survey and follow it up with interviews. And now I'm going to turn it over to Bridget, who's going to talk about that process.
Thanks, Brian. So in this survey, we worked with the School of Medicine, since they were also interested and concerned in faculty. Are faculty still continuing to volunteer to teach as much? And are they still continuing to give feedback? So we partnered with the School of Medicine to launch this survey in the Department of Medicine. We asked the faculty to tell us about had their teaching declined in the past 12 months or had it increased? What was their level of satisfaction? How did they perceive the teaching environment and the feedback environment at UCSF? And what else could the department do to support them as educators and increase their satisfaction? We launched the survey about a year ago, and we had 331 responses, which actually we were pretty pleased with, but the survey went out to every single faculty member in the department. So our response rate was actually 27%. We're not sure if maybe some faculty just thought this doesn't apply to me because I don't see myself as an educator or having a substantial educator role. what I'm going to walk us through some of the findings. I'm going to focus especially on the ones that seem relevant to the topic of feedback. And I'm going to cover this in kind of a SWOT analysis, so covering strengths, weaknesses, opportunities, and threats. So some of the strengths were that we did hear pretty high levels of satisfaction among the faculty. We looked at their satisfaction with pre-clerkship teaching, so more of the classroom-based, clerkship students or students in the clinical settings, and then residents and fellows. And 80% of them said they were either somewhat or very satisfied with the teaching process. They also highlighted that this is a place to work where people are very supportive and collegial. We have a lot of enthusiastic learners. We have very dedicated educators who want to be doing this work. And it's a place where education does feel valued. At the same time, we heard some concerns. Probably the biggest one was about the challenges of the compressed work schedules where attendings now work 1 week at a time versus maybe that in the past they used to work 2 weeks or a whole month on service, which just isn't sustainable anymore given the amount of work that people have. And the learners have a lot more electives, so they're in and out more. So it felt like it was really hard to have much continuity with a learner in the clinical setting. And that made it hard to teach in the ways that you'd want to teach and to give feedback. They highlighted challenges with the feedback system. So MedHub, the evaluations sometimes feel like they come at odd times, not when you'd want them to come, when the learner's fresh in your mind. The ratings that you're filling out maybe don't feel like the things that you'd want to give feedback on or are hard to interpret and apply. And then lastly, some people perceived a lack of learner engagement. So in terms of opportunities, what could we be doing better? There was a lot of comments about how we could improve the feedback culture here. And that meant that thinking about the environment as generally very oriented toward the positive and concerns that we're not giving as much critical feedback that supports learners' growth. So if we could shift toward a more normalizing the kind of constructive feedback that learners need for growth, that would be an important change. Enhancing people's feedback skills. So although we've done a lot of work in this area, people still felt like I'm not sure I'm the best that I could be at giving constructive feedback, or wanting more support when I do have to give a difficult feedback conversation. So is there someone I could talk to or run this by in advance? And lastly, creating mechanisms for support for feedback. So for learners who might need more support. So when I identify a learner who might not be meeting the expectations that we have, I want to know that there's a system in place to support that learner rather than feeling like I'm actually going to bear the responsibility of helping that person get to where they need to be. So some of the threats then that were mentioned were certainly concerns about increasing clinical demands, conflicting with trying to do optimal education, faculty feeling vulnerable in terms of their stress level and their concerns about what might happen if they do give constructive feedback to a learner. Will the program still support me in doing that? Also concerned, people are aware that learners are stressed and burned out and they're feeling concerned about their well-being. So that makes it harder to sometimes give feedback. And overall, we started wondering, is there something about a lack of trust here? A trust in learners and systems, even in themselves. So that led us to want to explore more in depth through these interviews. We invited on the survey people to volunteer to participate in an interview if they would like to share more on this topic. And we had 54 people volunteer for interviews, which is quite a large number. And we engaged in this study. Now, we actually know from the literature some of the reasons why people are reluctant to give feedback. And psychologists have called this the mum effect. Mum meaning keeping mum about unpleasant messages. So they made it into an acronym. I don't know if they needed to, but that's when people delay or distort or sugarcoat or avoid giving feedback that they think is kind of critical or negative in some way. And some of the reasons why they do that are for self-concern. So again, like that, this is going to be unpleasant for me. This is going to be uncomfortable. This may even make me sad or, worried about someone. I'm going to carry that with me. There's also concern for the other, like they empathize with a learner who's hearing this feedback and knowing it's hard. And there's concern about compliance with norms. So if this is a place where everyone expects to be getting praise and positive feedback all the time, and I'm violating that norm, what's going to happen to me? What are the consequences? So the interesting thing in the mum effect, and I was even thinking about this in Brian's diagram, is that it treats feedback as a one-way process. And we've started shifting our thinking to realizing feedback happens in the context of a relationship and a dialogue. So that can actually potentially help mitigate some of this mum effect. And we've been thinking about feedback as an educational alliance, which you could liken to a therapeutic alliance with the patient, which recognizes how important that relationship between the physician and the patient is, sometimes even more so than the treatment that you're offering. So in an educational alliance, we're also thinking about the importance of the relationship being just as important as the way that you deliver that feedback or the techniques that you use. So this educational alliance is a relationship in which both people trust one another, and they trust one another in the sense that we have a mutual understanding of our purpose here, of why we're engaged in this. So we are both here and invested in the learner's learning and growth. We're committed to acting in a way that facilitates learning and growth, and we have respect for and value the other person. So these are some of the factors in trust. Now, surrounding that, there's also trust in the environment or the program or the systems that can also affect the trust within that relationship. So our study was actually exploring more about this issue of trust. So we're looking at the role of trust in faculty members' constructive feedback practices. And we're using the concept of relational trust, which is a belief, a person's beliefs about the likelihood of another person or organization, so at that systems level, acting in desirable ways. And that's again, like in desirable ways, meaning supporting learning or respecting educators' efforts and commitment to education. So I'm going to turn it over to Griffin to talk about some of our methods and our findings.
So for the purpose of this study, to understand these concepts here at University of California, San Francisco, we developed our research questions and our interview guide based around those survey results and related literature that Bridget just demonstrated. We purposely selected from those who had completed the survey in the Department of Medicine and made themselves available to be interviewed to try to have some diversity in the divisions, the ranks, settings, and roles in which they work. And then ultimately, Bridget, Jackie, and myself conducted these interviews during the winter of this academic year. In all, we interviewed 23 faculty members that were well dispersed amongst different ranking. The majority were here at UCSF Health, but we did have representation from the VA as well as San Francisco General Hospital. We had 8 people from GIM who were split between hospitalists as well as primary care, and 14 specialists across 9 different divisions. We did have 1 researcher. And it's important to note that the majority of our faculty had experience working with both UME and GME learners. The majority of them also had experience working both in didactic as well as clinical settings. And for the purpose of the feedback portion of the study, we mostly focused on feedback in clinical settings. And as we set out to look into trust, what we found was a lot of conversation around risk as well. And what we found was that these 2 concepts that are described often by faculty are intertwined. It's difficult to say if one is driving the other per se, but we do know that the higher there is for perceived risk of giving feedback, or in some cases not giving feedback, the more important trust becomes. And this is in several domains. There's trust in self, ability to give that feedback, the trainees, receptiveness to that feedback, as well as the systems and cultures that support that. There's also domains of risk, to self and faculty, as well as trainees. And so because of the purpose of this conversation today, we're going to delve into each of these constructs a little bit more with a focus on those barriers that we feel like could be driving some of the decrease in particularly constructive feedback. But to not be total bummers today, we're also going to circle back and talk about some of those facilitators of trust and mitigators of risk that were clear amongst faculty that do support the feedback process as well.
Thank you, Griffin, for that great introduction. So we'll jump right into some of the themes that we identify in our study, starting first with this concept of trust. The first theme that we identified was a lack of trust in self, and this really translated into a lack of self-efficacy, where participants expressed a concern with the ability to give constructive feedback to learners effectively, while feeling some concerns with navigating implicit and explicit biases in the clinical setting. They also expressed concerns with being the right person to give this feedback. So for example, I feel concerned when I have to provide this middleman feedback or from feedback from a third party that I did not directly observe myself in the clinical setting. This is a quote to illustrate one of the participants' experience. It's really tough given feedback because it can be taken the wrong way. It's easy to be nice, but it's very difficult to give critical feedback. I'm still struggling with it. I'm not quite sure I know how to do it well. Number two, lack of trust in trainees. Here, participants express a degree of skepticism with regards with giving trainees feedback and their ability of being, do I really want this feedback? And are you going to be receptive to this feedback? And then what happens once I give you this feedback? How are you going to handle the feedback emotionally? I've perceived a difference in how feedback is received by learners. Not every learner, it is obviously just a general trend, but a sense that constructive feedback is often received much more negatively and with a greater degree of skepticism than maybe previously, even when I was in my own training, and maybe a little bit of more of the sense of kind of us versus them in terms of the learners versus the educators that I've never perceived when I was a learner. Number three, lack of trust in systems and cultures. Here, participants experience considerations around institutional support to give quality feedback and support struggling learners. They also express considerations around how feedback from learners is handled, how the culture supports constructive feedback, and effectiveness of the written feedback system, particularly to MedHub, which we know is everybody's favorite. And our quote to illustrate the theme for this group is the feedback didn't land well, and the response of the training program was that I had to re-meet with the learner twice after that in a mediated scenario where I basically just re-delivered the same feedback. And it kind of jaundiced me in giving this constructive feedback. I love this quote because the word jaundice really hits a message home and it really paints a picture of how this participant felt with regards to a lack of trust in the system. And then switching gears a little bit into this construct of risk. Here, our first theme is a perceived risk to faculty. So participants expressed concerns and fear with receiving harsh or retaliatory feedback, fear of feeling this negative emotions within oneself and not knowing how to deal with these negative emotions, and also fear of consequences of breaching cultural norms. So for example, not wanting to be the only person to give constructive feedback or the bad guy because I'm giving constructive feedback. There's a lot of fear being perceived as someone who is not aligned with the students or being written off as a bad educator or getting harsh feedback yourself. And then finally, this perceived risk for trainees, you're going to see an overlapping theme, particularly between this slide and the prior one, where there's a lot of negative emotions being generated and fear to actually generate those negative emotions. But here is a fear of generating the negative emotions in the trainees, along with a fear of causing psychological harm to a trainee as well, and not wanting to exacerbate feelings of burnout, stress, imposter syndrome, and a lack of belonging in a culture, which is very important, particularly amongst marginalized communities. I do candidly worry sometimes if I'm giving constructive feedback to someone who's from an underrepresented group, if the feedback is in any way not glowing or is suggestive of constructive things to do differently. I think, is this going to be taken in a way where they understand that my intentions are good, to help them have a better learning experience or to learn more? And I do worry about offending people unintentionally.
And as promised, we do want to end by pointing out some very real facilitators of trust and mitigators of risk that faculty consistently talk about that do support the process of giving even constructive and difficult feedback. And those included a strong sense of responsibility or role identity. They included positive or rewarding prior experiences, strong relationships with the trainees they work with, as well as supportive environments and expectations around giving feedback. And this is a powerful quote that demonstrates that. The biggest, most important thing is it's my responsibility. You don't let a trainee just flounder. That's horrible. It's toxic. This is our responsibility. I feel confident in myself enough in my institution to say, hey, I'm worried about this. And with that, we'll pass it back to Brian to lead our moderated discussion.
Thanks so much. We're going to now move on to our panel and ask our outstanding group of experts to reflect on what they've heard, how that resonates to them in their individual spaces. We have Mia Williams, who is an APD in our UC-PC residency, Madison Malone, who's a chief resident, or I guess was a chief resident like a week ago. Right. Carly Zapata, who is the program director for the Palliative Care Fellowship, Atif Qasim, who is the program director for the Cardiology Fellowship. And then we've also invited Sandrine Van Schaik, who's the vice chair for education in pediatrics, but is also the director for the Center for Faculty Educators. And so we're going to ask them to come have a seat up here, and we'll spend about 10 minutes asking them to reflect on what they heard today. So I may just go in order who's closest to farthest away. Sorry, Carly. So Carly, you are a program director of the Palliative Care Fellowship. And I think one thing that has been quite remarkable is that when we look at the learners' feelings about feedback from your faculty, they're always quite positive, and that your group is quite successful in this space. So that was one of the reasons we wanted to have you here today. I was wondering if you could reflect on what you heard, how it seems with your own group.
Unmute myself. How's that? Better? Thanks, Brian. I was just thinking as I looked at that chart that in some ways I question whether our ratings are so good because actually our fellows are mostly getting positive feedback, and that's why they're so satisfied. So I certainly don't think that that single item on the ACGME survey is entirely reflective of what's happening in our program or any program. And I think there are potentially two things that are advantages for us, and whether or not those are unfair advantages is a separate debatable question. But I think the first is that by nature of our specialty, we have a lot of communications training, and not everyone, myself included, can always apply the communications training that we get to interact with patients and families to other realms of communication. But I do think it is so deeply ingrained to us. I think to Bridget's point about considering your relationship with your learner to be somewhat analogous to your relationship with a patient. And if you have challenging feedback that you want to have a conversation about, not marching in to a room with your learner and saying, and delivering bad news without having asked for permission, without having asked for their understanding and where they are on their learning trajectory for that course of the year. And so some of that comes, if not naturally, maybe more naturally after having a lot of training in dealing with that specifically. And I think the other advantage that we have, which again, may or may not be unfair or relevant in other specialties, is that we have really robust interprofessional teams. And I very much want to give credit where that is due to our interprofessional team members, because certainly I, as a physician, and I think many of us feel so beholden to efficiency and seeing our next consult or seeing our next patient in clinic when we're behind. And I have had plenty of experiences where I've left a patient encounter, like a family meeting, and just forgotten to have a conversation about that with the learner because you have to get to the next thing. And it's very much a credit to our other team members. It may be the chaplain or the social worker or the nurse on our team who says, I know that we have to get to this next thing. We're going to take 2 minutes to just check in about how that went, what's something that you did well, what's something that you want to take away from this experience. And I think there probably are other programs where there may be interprofessional team members who could play that role if they kind of feel comfortable in the hierarchy of that situation, which I know is not always the case, even for us. But just really want to acknowledge that I think the culture of other disciplines pays much more attention to relationship-centered communication and kind of having a safe learning environment and facilitating that trust. And I think that has benefited all of the physicians and the learners in our group too.
Great. Thank you. Madison, I know that you are not a trainee anymore, but I feel like I've always seen you be a very strong advocate for the trainees in your chief resident role. And I was wondering if you could share your thoughts from that lens.
I think one of the really tricky things is that when we talk about learners, even in like kind of the survey, we group all learners together, including UME and GME. And I think that the learning environment, the culture, and even the purpose of feedback in those different groups is wildly different. And that medical students come in an especially vulnerable situation, they're being constantly assessed. And that feedback that they're being given is part of grading. It's part of like promotion. It's part of, this is going to go on my MSPE. I'm trying to get a letter of recommendation so I can go into orthopedics or hopefully medicine. And so there's a totally different mindset about like, this feedback is evaluative that I'm receiving. This constructive feedback has implications for my career. Whereas I feel like for our trainees, I hear like up and down all day that our trainees just desperately want feedback, constructive. And I mean, everybody likes positive feedback, but they really they know that they're trainees. They know that they're here to learn, and that they can't improve to the point that they can practice on their own without being told what they're doing wrong or what they can be doing better. And the purpose of that feedback is their own personal growth. And they, I think, by far and away see that. And so it's much less of a, I'm about to give you a grade in this feedback, and it's much more of a partnership. So I would say that like learners just desperately want constructive feedback, and it is really hard to give. As like an attending this year, I had to give constructive feedback, and I was like, this is not very fun. But I have also been fortunate to receive incredible feedback from like constructive as well from some of like the most incredible medical educators that we have in the department, like Brad Sharp or Brad Monash. And Brad Sharp gives a lot of feedback. He gives a lot of feedback. And it's like, I think that you should have stood there. I think that you should have communicated in this way. And I think either because of the skill that he has or the trust that we have in him and similar educators, and in the way that he's just, we know that he's committed, he has that trust to our medical education. Like Brad Sharp is also one of the highest rated medical educators in attendings, even though he's like the hardest, right? And so thinking about like what qualities does he have and like what qualities come up in this research that lend benefit to that establishment of trust in our trainees, I think is one of my biggest reflections.
Great, thank you. Mia, in your role as both the APD and then you're also representative of the anti-oppressive initiative in the School of Medicine, what perspectives do you have?
I think the things that jumped out are a lot of similar themes in terms of that relationship building and being in community towards growth and what's that mental model for what we're doing here together. And I think if you were to ask any of the staff, the faculty, the trainees, the students, they'd say like, we're here to provide excellent care. And I think as faculty and as trainees, people would agree that like, I'm here to be a great doctor and to facilitate the growth of our residents. And I'd say putting on my hat as APD, where you see that is this desire for feedback. And what stuck out to me was one of the comments from the faculty or like the themes of being concerned about maybe residents not wanting feedback. And I think in our experience, that's not what we see. What we see is a true desire, like you're highlighting, Madison, about that desire for feedback. And what it makes me think about is what is our mental model for what feedback is? As the feedback champions, part of that intervention, like you're highlighting, we talked to everyone and we talked about feedback as a conversation where the learner, the trainee starts that and you get to see what their goals are. And we talked to faculty about that. And I'm not sure if we've ever talked to our trainees about that. And what does it mean if we all have an understanding of what feedback is? And I wonder if that gets to that part where we know that people are aligned about providing great care, about helping each other grow, then is it something about the modality that if we understand that better and really put some of these things that we know from the literature to practice, we can help each other grow together and be in community together. And then the community part makes me think about my work in UME with the AOCI, in that there's a real sense from faculty of, I think, a duality of fear of being canceled, but a fear that they are going to harm people. And what we hear, I think, in the GME and the UME space is we're getting resources, those resources are helpful, but we need practical ability to build those skills up so that we can communicate with our learners, build with our learners, and time for that work so that we can build that up. Highlighted like relationship-centered communication. And so that's the other thing that comes in is, in my experience, when you sit down with faculty who may initially be very scared about having any, like, I don't know how to do this anti-oppressive thing. Like, if you give people space to do the work and the right amount of coaching, you see people like just incredibly blossom. And I think it's a testament to skills and also time to do that work.
Great, thank you. Atif is, I guess, the Associate Chief of Education and Cardiology and the Program Director. I think the cardiology programs have had a little bit more challenge with faculty feedback, and I'd love to hear your perspective.
Yeah, I would say that a lot of what you presented certainly resonates with us, and we've certainly spoken to our faculty. And over the years, the interactions between faculty and trainees has gotten shorter. And so we can even look at our own fellowship. Certain rotations like Echo and Cath, a trainee may work with 6 or 10 different faculty within a week. And so you can imagine one faculty member, if something's off for one day, did that trainee just have a bad day or what's going on? They feel very uncomfortable giving highly constructive feedback. And we've thought about different ways to approach situations like that. I have noticed that when you put either faculty or fellows together in a room to talk about their experience on a rotation, that actually helps quite a bit. So we've transitioned to giving group feedback so that those 10 faculty, who are on with that trainee on that rotation for 2 weeks can come together and give a consensus opinion, which is then summated and given by one faculty member at the end of that rotation. Now, MedHub doesn't exactly fit, for that model. So it's important to start thinking about different models. But I will say, just to resonate, with what others have said, it's super important to give trainees feedback. When feedback is given too late, that's sort of one of the worst things you can do, especially when that trainee feels like they could have done something different to change things. And on the flip side, I would say, one of the most rewarding experiences I have in giving feedback is when you have a trainee who is struggling and you provide them with some support and help to see them change and become so much better at the end. It's just amazing. I mean, if you take someone who's great, who's going to do well in fellowship, no matter what you throw at them, that's great. They're going to do awesome. But if you take someone who, really is struggling and you can provide that support and see them grow, that's really rewarding as an educator.
Great, thank you. And Sandrine, now from the outside of Department of Medicine perspective, is this just us? Can you share a little bit about what you think?
Yeah, it's just you. Everybody else does great. Actually, I just looked at all the ACGME surveys for the entire School of Medicine, and I think there's only 5 or so out of the 60 programs where it's in the green, meaning above 75% compliance with the feedback ratings. So I think this is a bigger problem. It's a very tricky problem. It's actually, I think, a wicked problem. And I would caution us a little bit about thinking about as one problem. One issue I see is the use of the word feedback. We're equating it even in this presentation, and everybody does this, so I'm not like pointing fingers here, but we're equating written evaluations and frequency of written evaluations as if that's the same as the quality of oral feedback. Learners oftentimes don't recognize that if you say, hey, you should stand over there, you can actually have better eye contact. They don't recognize that as feedback. And so sometimes I'm actually thinking, I remember Catherine Lucy saying to me several years ago, maybe we should just abolish the word feedback. And I said, oh God, no, because then we confuse everyone. And we're so good at that in education, confusing people. And at the same time, I'm thinking we actually should really reframe this as a coaching conversation. And if we think about this as coaching, then a lot of these concerns actually go away, because then it's not necessarily critical, constructive feedback, but it's saying like, hey, I want you to actually become really good at this. So let me talk to you about this. This issue of the relationship becomes different, because we always talk about that, right? Oh, we don't actually get to know our trainees that well anymore. But an anesthesiologist sees a patient for maybe 20 minutes before they fall asleep or put them to sleep. And I think they would be offended if they said that you don't have good relationships with your patients because you can't deliver the relationship-centered care because you're an anesthesiologist. We can actually do things in the moment as long as we start to say, this is about coaching, and we don't have to evaluate the whole person with this one feedback comment that I want to give. What I tend to say to people is like, when you go to a restaurant and you order a cup of soup, you just have to evaluate the soup. You don't have to evaluate the entire restaurant. Okay, maybe you can also something about the wait staff that brought it to you, but you don't all of a sudden have to become the critic from the newspaper to say this restaurant is no good because the soup was cold. I mean, come on.
Thank you. This was great. I appreciate your reflection. What I'm going to ask you to do now is have a seat back here. We're going to present kind of our version 1.0 approach to trying to address some of these issues. And then I'm going to have you come back up and give us some feedback on where we're going with it. All right. So given these issues that we have identified, we decided in the department that we really wanted to take this on as an important initiative for this coming year. At Bob's suggestion, we had to name it. So we're going to call this the Department of Medicine Facet 360 Feedback and Assessment to Cultivate Excellence in Training. And I think you've heard earlier that we've identified kind of 5 key areas: lack of trust in faculty self-efficacy, lack of trust in trainees, faculty lack of trust in the system, faculty perceive risks of harming trainees, and they perceive risk of harm to themselves. And as Sandrine, I think, highlighted, this is a wicked problem. It's a problem that involves systems, culture, trainees, and faculty. And there really is no one single solution. If there was, faculty development that they did several years ago would have fixed this problem. But we really believe it's going to require a multi-pronged approach to build trust. And what we're going to be doing is working with program leaders on messaging, engaging faculty and the learners together. Further study learners' perspectives. We just gave you the faculty perspective, but we need to better understand the learner's perspective. And we're going to need to modify existing systems and maybe build new systems to make this work. So I'm going to take a couple minutes to lay out some proposed ideas that we have for our stage 1, our version 1.0, and then we'll bring the panel back up. So what are countermeasures to address lack of self-efficacy? So we heard from the faculty that there are a number of things that I don't think that are regularly part of faculty development around feedback that we need to bring in. Yes, we want to bring in core feedback skills, but are we specifically educating them about how to do it in short periods? Are we including bias training in there? And are we telling them what are the systems to support trainees? Those were things they were asking for. And then in partnership with Sandrine and the Center for Faculty Educators, how do we bring faculty development to faculty in ways that work for them? And so Sandrine has partnered with a group called Snap Instruct, and we're going to hopefully in the coming year be able to roll out a pilot program to provide more bite-sized AI-powered faculty development around feedback based on curriculum that Sandrine has developed. How about countermeasures for issues around lack of trust in trainees? So I think this is really where we need to bring the trainees and the faculty together. We're going to launch a trainee and faculty feedback task force to help identify strategies for trainees to partner in the feedback process and inform faculty development. We also are going to be doing a partner study to the one we've just done, where we're going to be interviewing trainees, fellows, residents, and really understand their preferences. That will be starting this summer. Countermeasures for lack of trust in system. Lots of issues here. The system, busy clinical services, there's really lack of time for feedback. So we're going to have a task force look to address some best practices. There are already some programs that are coming up with strategies that will help here. And so we want to tap into that work. We think that the written evaluation system stinks. Everybody knows MedHub is really challenging. Can we think about other ways to do assessments? We rely simply on faculty feedback. Are there other ways that we could do it? Can we improve the forms? And then we're doing some initiatives to try to think about how can we use apps to bypass the actual MedHub system and do things that are going to be more helpful. And how do we use things like AI to give us other ways that we can assess learners? We also want to let faculty know that we're creating better systems to support trainees. We are launching in July a Department of Medicine GME coaching program led by Vanessa Thompson, supported by Alyssa Perez and Jesse Ristow, and really with the 3 goals of normalizing the need of support for trainees, centralizing the process, and providing easy access to broad resources. Countermeasures for perceived risk of harm to faculty themselves. So a couple ways that we're thinking about tackling this. One is working with the leadership in the Department of Medicine Promotions Committee or the Promotions Committee on the campus itself to be more explicit about how trainee evaluations impact promotions. And then take a step back and think about, well, why are we using trainee evaluations as the main metric to determine effectiveness of faculty teaching, and really thinking about, should we be changing the model to a more holistic evaluation of teaching, where we really think about getting peers to evaluate your teaching, learner outcomes, and trainee feedback together. Perceived risk of harming trainees, working with leadership in GME programs to talk to their faculty that feedback is really important, and really balancing their messaging around the importance of feedback and trainee well-being. And we talked before about creating faculty development that really addresses the faculty concerns. And we talked about some work that will better partner our trainees and our faculty together to hopefully build trust. So with that, I am gonna bring the panel back up and ask for their feedback and input on what they think would work here, what would not work, what other ideas do they have? We can start with you, Carly.
I think this part of it brought up a lot of thoughts, and I love the idea of getting more of the learner perspective. That seems like a huge part of this equation, but I also have thought a lot about in this presentation talking about trust and all of the risks that people perceive. And I think to Asif's point earlier, I also wonder if it's worth exploring still from the faculty side, if you were to go back into a survey, about what people perceive as the benefits. Because I think when you're a program director and you get to see somebody improve over the course of that program, that's really satisfying. But if you're one of the 10 faculty who works with someone for a half day, those faculty may only perceive a downside to giving any kind of constructive feedback. And so really thinking through from the faculty side, what people perceive as the benefits, and focusing on that to kind of balance that risk and benefit equation. And there was another thought that I had that now I have forgotten. Maybe I will pass it to Madison.
Took notes just because I knew I would forget. I think I hold an interesting perspective, having been an attending this year, but also just having been a resident in like the past 4 years. And so I think I hear a lot of perspectives about this from a lot of different angles. And I'll say that from the faculty side, one of the things I hear is that feedback is just another additional thing that faculty are being asked to do. on a long list of 10 other duties, right? In addition to taking care of patients, they're also leading a team, setting an example, trying to give feedback to all different levels of learners, helping struggling learners on the team that have different needs, making sure that they're teaching, making sure that they're like setting a positive tone. There's a lot of different things. And then also taking the time to give this feedback, which people perceive as having risk. And I think one of the things that has come up this year is that, education generally is poorly compensated. And so, being and attending on the teaching service pays less. It doesn't matter to me. I just got paid as a resident, but allegedly they tell me that you get paid less when you're on the teaching service, even though you're being asked to do 5 times as much. And so I think from a faculty perspective, I can imagine that makes it feel overall less compensated, and maybe that education overall maybe feels less valued. And the residents know this too, because it gets talked about. And so I think they feel like, wow, I think when you come to teach me, that's not as valued from a monetary perspective. And I think that influences a lot of this. But I do think that at the end of the day, as medical educators, just like as teachers, right, it is a vocation and profession. And so it really is our responsibility to give hard, critical feedback to our learners, because it's part of our duty. And so I think, really emphasizing that in addition to kind of all of these other protective measures, and giving people the support, obviously, to do that is critical.
Thanks.
I think one of the things I really appreciate about this is that there is this aspect of like relationship at the center. So there's both like the actual building the relationships and valuing the trainee perspective and having a conversation with faculty as to what would work and wouldn't work and building that together. I think that co-creation really speaks to me. And the other part that I think is really important in considering this, and now I'm having the same thing, thank you, is an aspect of what you were talking about, Madison. I think I have a colleague who says, like, make working at UCSF the sweetest gig so that everyone stays here and wants to come here. And I think increasingly what we hear is, like you were highlighting, the different pressures that are people holding. And obviously we're here because we care about our learners and we're so passionate. And there are also these other pressures. And so how structurally beyond like the interventions here or as part of them, do we support people going, you know what, I can see 3 patients less today because like I am supported in seeing 3 patients less today, and then I can develop these things, is something that I suspect a lot of faculty will be wondering.
I'd like to highlight just another thing that was mentioned, and something we're certainly working with over the next few years in our program, and that's the learners shouldn't be the only source of evaluation for the faculty. I mean, this is a teaching institution, right? And part of our job and our mission is to teach. And if you look at schools, right, if you look at my school, like if you look at all the evaluations from the kids for their like 5th grade teacher, if you just looked at that, you may like say, well, maybe we shouldn't have this teacher in our school anymore. But what happens is, the principal or other, faculty or teachers sit in that classroom and observe and watch that person teach. And yes, we have a peer observation program here at UCSF. It's maybe not as well used as it could be. Why is that? Because it takes time and it takes effort. And honestly, the best is when you have a near peer, another person who does the same thing as you, watch and see what you do. And we've experimented with that. And frankly, it's super helpful, not just for the person who's getting observed, but for the person who's observing to see, wow, this is how someone does this. I could learn from that. And so we're starting to do that more and provide protected time for that. It'd be great if that was something that was easy to do across the department. But I think we need to start having other ways to help evaluate faculty as part of their promotion process and otherwise, not just the feedback from the learners.
Yeah, I think that's a really good point. And I think we actually have, with our current academic affairs people, some room to push for that. We've had some positive conversations. I just mostly want to say, I think this is terrific work. I'm really glad that you approaching it as a multi-pronged problem. I'm also going to ask Bob, how much are you paying all these people for this? Because then I'll go to my boss and say, hey, you know what they're doing in medicine. But I think actually one of the really good things here is that you are leading the way. And I hope you really consider partnering with the academy, with the Center for Faculty Educators, so that others can follow in the footsteps. In terms of challenges, I see a million challenges. This is hard work. My biggest thing that I really hope you'll think about is how are you going to measure success? And I'll tell you one thing, like the ACGME survey, for example, I wouldn't go for it because we actually saw in our department, pediatrics, where we did a ton of work on faculty development. We went to every single division, not just a few, every single division, made it mandatory, et cetera, to do this, like in the moment feedback, think about coaching, et cetera. And not all ratings, some went up, but not all ratings went up. And then I asked all the fellowship directors, can you just go talk to your fellows and see what the problem is? And one group said, we're getting so much feedback, it just drives us crazy. I don't have to hear every single step of the way what I'm doing well and what I'm not doing well. I'm like, okay, great, thank you. Okay. We are actually, there's a fellow in our division that is doing a research study right now, and I'll loop in with the group, looking at Black trainees' experiences with feedback. And they say loud and clear, we actually also really want to hear praise. You did a great job doing this, period, nothing else, right? There's some generational differences in what people actually expect and don't expect. And that creates tension with the faculty. So we need to adapt our faculty development and not say, we did this one workshop and we're going to keep on doing that every single year. So I think we have a lot to learn together. And one of the things that I feel we're not very good at in academic medicine, especially in education, is accepting that this is a constantly evolving thing, right? We do curriculum development every 10 years, and then we say, so we did that. And I'm like, but the world around us is changing so fast. We need to continuously adapt. And this problem is a problem because we actually are not adapting our feedback practices, our MedHub systems, our faculty development fast enough to meet the needs of our current learners. And I think we can. And then there's the big challenge of, the time for the faculty. We need to keep on pushing on that issue, the recognition of it, but also a little bit this like, maybe this is too Pollyanna of me, but the more we say, oh, it's so bad at UCSF, the more we all feel so bad at UCSF. And we were in a session yesterday, you were there, where one of the participants said, well, I just came from Kaiser, and we don't have this at Kaiser. We don't have the opportunity to do a day-long Teach for UCSF certificate. So it's not all that bad, and we can actually collectively create a culture where things aren't all that bad. It's not that bad. I mean, it's pretty bad, but it's not that bad.
Thank you. So what I'm going to do now is I promised Bob he could have a couple minutes at the end. So maybe have everybody stay here. I'm going to turn it over to you.
Thank you. Well, first of all, a spectacular session, and it makes me proud of the department for taking a lead in this. It's a really important, knotty problem. It'd be easier to just kick it down the road and ignore it or not apply science and rigor to it. So I want to say that. Also, Madison, who's now Chief Resident Emeritus, thank you, and Ty for a spectacular year. Thank you for everything. One thing we could do tomorrow is we could start calling it coaching. And I found when you said that, or whoever said that, I saw a lot of, oh yeah, that's kind of what it is. And maybe there's some reframing here. Sandrine, do you recommend we do this tomorrow? Just start calling coaching. Maybe there's another thing that we got to call feedback elsewhere. Or you tell your resident student, like when you are asked about feedback, that's coaching thing that we're doing. And so give me a good rating. But you think it's wise to begin reframing it as coaching?
I think it will make it much more clear why we're doing it, right? We're doing this to help you.
Yeah. One thing that struck me was we sort of moved very quickly to, there's a skill deficit here, and the skill is all about communication. And I guess personally, I find the skill is partly about the assessment, am I really good at figuring out, are you good at that thing or not? And part of that is, have I seen enough reps that I don't have enough time to have seen you do this thing? Part of it is like, unless I'm pretty sure that you stink at this, I don't want to say that. And part of it, I think, the Brad Sharp, one of the messages online was we should just clone Brad Sharp and we solve this problem. But sort of the idea that I could give you coaching, let's call it that for the moment, on where you're standing. It's like, oh, I didn't know that was even in bounds of the things that I could give to you in an effort to make you be better. So I don't know if, Brian, do you want to, anybody up here, any of you guys address the idea of part of the deficit here is our ability to understand what we want to give coaching about, as opposed to, are we good at the communication part of it? Anybody want to address that up here? Yeah, go for it. Is the mic around? Yeah, grab the mic.
I'll be brief in case other people have lots of things to say. But I think a lot of us probably overthink this a little bit in terms of the difference between just offering feedback on something that you've observed versus like evaluating like the whole restaurant based on soup. So like, I think it's within all of our bounds to say like, I saw that this maybe this presentation took you 20 minutes and we should aim for 10, like just on observable behaviors that are very low inference.
Yep.
I don't have to say you're bad at presentations. I can just say, this is what I observed. And this is like these are some guiding principles on how to improve this.
When you use that term, I don't think the patient understood you.
Exactly.
That was a very medical term.
Exactly.
Very neutral, but I observed this and I have, at least in my own assessment, I could imagine a different way of doing it.
Exactly.
Yeah, great. Any thoughts? We spend the next 10 minutes working, so.
I think that's actually spot on, and then we need to make sure that our learners get used to that, right? Because they will otherwise say, well, like normally I wouldn't say that, or this was just the one time that I said that, right? And I think actually we also have to acknowledge, all of us, that constructive feedback, someone saying to you, that word wasn't very helpful, or that presentation was long. That's not what I want to hear. I just got reviews back from a journal for a manuscript that I submitted. They didn't love everything. They got better than
Yeah.
And so I think if you can start by saying, I'm here to coach you. Some of the things that I'm going to say, you might not agree with, and some of the things you're not going to like, right? But just take it, think about it, and then decide what you want to do with it.
Great.
End of story.
We're getting a little long, but let's go a few minutes over. It's an important enough topic. Any questions from the audience here? Or Bridget, yeah.
I just wanted
Let's
to
get a
comment on
mic for you.
I think we did hear from some of the participants in this study about, I'm not actually sure if this is within bounds or out of bounds. So they're definitely, they wanted more clarification, I think. I mean, so it's really about how do we convey that message to people of, yes, it is your responsibility. Yes, you can give that feedback. So.
Yeah. Do you have any sense of another thing that didn't really come up is sort of micro feedback versus the big feedback thing at the end? And do people want, it sounds like the Brad Sharp example is a lot of micro feedback in the moment. I noticed you did this. And at least in my view, if you'd done that, it would have been a little bit better, as opposed to this sort of big lollapalooza at the end. We're going to sit down somewhere for 15 minutes and go through the whole thing. Do you have any sense of which one's better, or what people want more of or less of?
I'll just say it was a concern of mine that we were conflating these two things. And I think you're spot on to say, sometimes I think when they talk about the difficulty, they're talking about the big feedback, and maybe they're just giving that little day-to-day stuff and not even really thinking that maybe that's what we're talking about in this interview conversation.
Yeah,
I agree. I feel like a lot of the day-to-day stuff is ignored and not considered feedback, but is very helpful for their growth. But then at the end, they want to know, well, how have I done? In particular, how have I improved? And if you're able to tell them, look, in the first week you were like this, we gave you some feedback, and then by the end, wow, now you can like do this, this, and this. That's super helpful. So think it's a matter of perspective.
We actually have to leave the classroom. There's another group coming in. Carly, last comment, if you want.
I was just to your point, Bob, about how good are we at identifying how someone needs to improve and have that be very specific. And I think there maybe is a deficit around faculty education around what is actually expected at somebody's point in training and how they compare. Because I think we have the luxury of having trainees who generally are fantastic, and that is our marker. And so when someone is, we do compare learners, even if that's not what we're trying to do. But when we might view someone as struggling who actually is right where they're supposed to be for halfway through their residency or halfway through their fellowship, and really making sure that our faculty know where people are supposed to be when they're giving hard feedback versus where there are just some things around the edges or someone is actually on track. Even if that's not by comparison to the rest of our outstanding trainees, are they still ready to graduate and move on to the next step?
Great. And don't forget, the whole conversation has been on constructive, but also giving people positive coaching is really important too. Thank you, everybody. This is a fabulous session.